Good afternoon, one and all. A lot of discussion have already been made regarding ocular tuberculosis. But this case, I think we are not sure. This patient is a 52-year-old male who presented to us with a gradual painless diminution of vision in both the eyes for 2 months with a visual acuity of counting finger 2 meter and 3 meter in right and left eye respectively. IOP was normal. Anterior segment showed early cataract but moderate cells and flare. And fundus examination revealed grade 2 vitreous haze with multifocal choroidal patch, edematous hyperthermic optic disc, but no vascular seeding, on the indentation, snowball exudates were appreciable. The systemic examination showed there was no fever, there was moderate weight loss, no lymphadenopathy, and there was no contact history, and the patient didn't agree for the pathology test. There are both mouth ulcers as well as genital ulcers. So, provisional diagnosis of a case of sudden acute infectious panuveitis with retinitis or retinochoroiditis and orogenital ulcers in a patient with hypertension and other comorbidities kept in mind, and other blood tests were done. So to me, I think three possible diagnoses came to my mind, like tertiary syphilis, Behçet's, or ocular disseminated tuberculosis, because of these blood findings with mild lymphocytosis. ESR was 45 millimeter. VDRL was positive. Mantoux showed a strong reaction of 15 millimeter. So with after 4 days, when you again took picture, the choroiditis patches are more prominent. Vitreous was started little bit clearing, so we could take good picture. OCT was normal, and posterior pole appear normal. The angiogram showed disc hyperfluorescence and peripheral patches of choroiditis.
TPH has been done?
Yes, sir. I am coming to that. I'll discuss one entity individually. TPHA was negative. I'll come to that.
Oh, okay.
So, with disc hyperfluorescence and early hypo and late hyperfluorescence of the choroiditis patches. So, as Dr. Viswas was asking, we did TPHA, which was negative, which ruled out syphilis. Behçet's, it was difficult to rule out because the patient denied for pathology, and genetic subtyping was not done. So the third entity which were in our mind was tuberculosis, and it was supported by a strong Mantoux as well as high ESR. But we lost the patient to follow-up, but we have ordered for ATT and oral steroid. As to support our diagnosis, we searched the literature, and it was found that a good number of cases had oral and genital tuberculosis to present as a relatively rare manifestation of tuberculosis. So the take-home message is common diseases can have uncommon or overlapping presentations, and one should look for it to cleanse them early for better possible outcome. Thank you.
I like to think common thing first, and 2 plus 2 I want to make it 4, and I would consider that Behçet's disease would be the first possibility in this case. The Behçet's disease patients, nothing prevents them for getting a MANTU positivity, because tuberculosis is a predominant systemic disease, systemic infection in our country. To have oral as well as the genital ulcer due to TB, and also having an retinitis lesion is due to TB, to my mind is quite unlikely. And you don't need an HLA-B typing. And actually I talked with Dr. Tutkun, who is an authority on Behçet's disease. They stopped doing that HLA typing for Behçet's disease now. They say that it's so non-specific.
So I agree with you, sir, because the patient did not turn off. I have ordered for the pathology, and first time he did not agree. We could have done it next time when he comes. So might be.
In fact, I did a paper with Sir only. So in Indian subcontinent, the Besset's presentations are not always the scheduled, the four categories it has, and rather it has a milder variations presenting with one or two symptoms, signs, one or two signs. It does have
Incomplete basis.
incomplete Besset's.
You need to have oral aphthous ulcer to call it Besset's uveitis. That's a must, IBD classification. Do it. Is it Besset's? I'll put money on that.
Full amount.
No, I just do. I'm not saying that I'm all the time correct, but I'll put my money on basis. We'll move to the next case.
Yeah.
There's
Thank you.
5